Welcome everyone, and thank you for joining us today. My name is Leah Boone and I'm the National Coordinator for CAFC's Canadian Pediatric Decision Support Network. CPDSN is the data sharing and benchmarking arm of CAFC, and today we are delighted that we have colleagues from BC, Alberta, Manitoba, Ontario, Quebec, Nova Scotia, and our colleagues and partners at CIHI. So welcome all. We're hoping that we can entertain you and stimulate you and help you learn about a ground movement for a proposed update to the PCATS code in order to enhance surgical wait times data for children. For those of you who missed last week's excellent presentation by Mary Muir, who's one of our panelists today, Mary delivered an exceptional presentation on how pediatric surgical wait times data can be used in an organization for very positive change, increasing access, improving workflow, and enhancing our ability to service children who are waiting for surgical intervention. So for those of you who've missed that, you may want to go to CAFC's website, and I'm asking my colleague Samantha DiLeonardo here to walk you through where you might find this a recording of this presentation. I urge you to go and share that with your colleagues. It'll really is a presentation not to be missed. So in follow-up to that session, and when we talked about the importance of the PCATS codes as a fundamental basis for surgical wait time management, today's session will focus on how to improve the PCATS codes, why there needs to be an update to those coding standards, and what difference this can make, and what would be possible model for making these updates. So I'd like to introduce you to the panelists that we will that have joined us today. Our panelists are unmuted and will be sharing the presentation today and making comments, and we urge you to ask questions along the way during this presentation. You have a voice even though you are muted, and the way to access that voice is through your chat box or your chat menu in your control box. So feel free at any time to send us your question, and we will intermittently, where the presentation will allow, stop and ask your question on your behalf. So joining us from Alberta Children's Hospital is Dr. Frankie Fraulein, Plastic Surgeon Chief of Surgery for Alberta Children's Hospital. Mary Muir, who's the Pediatric Surgical Wait Time Site Lead for the Stollery Children in Alberta. Sean Hillhouse, who's Patient Care Manager for Operative Services at the Stollery. Dr. James Wright, Chief of Perioperative Services and Surgeon-in-Chief at the Hospital for Sick Kids and current Chair of PSCC. Yuri Iwakata Tesoro, Executive Director of PSCC and former Canadian Pediatric Surgical Wait Time Project Lead. Many of you know Yuri well. Elaine Orbine, President and CEO of CAFC. And Samantha, I forgot to put you on that header, but most important, our technological driver today, Samantha DiLeonardo, who is CAFC's program assistant. So to get started, we have a couple of polling questions, so we get to know our audience a little bit better. And so you can also get practice using your technology. So the first question we have, and it'll come up on the screen momentarily. For some reason we can't see it, but they should be able to see it. Okay. Yeah, it's up there now. Go ahead.
I don't know why it's not coming up for us. What's happening when we were...
We can see it, Samantha.
Okay. So Mary, can you read it out, please?
Sure. So the first question is, how familiar are you with PCATS codes? And please select one. Very, somewhat, not at all.
Okay, so everybody was quick on the mark. So 60% of you said you're very familiar with PCATS codes. That's wonderful. 40% are somewhat, and 0 not at all. So this is really, really great. Thank you so much. The next question, do you currently submit pediatric surgical wait times data to CIHI? And you have option 0, yes, and you submit via paper, 0, yes, electronic, no, or unsure. And if you want to call a friend, you may, but I see that as the information is coming in, everybody is pretty cool with it. Okay. So it is a very interesting breakout that we have. So 75% of you said yes, you submit your surgical wait times data electronically to CIHI, and 25% are unsure. That's great. Thank you so much for that. Okay, so at this time, I'm going to hand the baton to my colleague Yuri, who's going to share with you the story about how surgical wait times data for kids found a new home, and just give you a very brief overview of that, just to sort of set the tone. Over to you, Yuri.
Hi, thank you, Leah. So to address the timely access to pediatric surgical care, Health Canada provided funding for the Canadian Pediatric Surgical Wait Times Project, or the CPSWT, from 2007 to 2011. It was the first national project in Canada to develop and implement a system for measuring, monitoring, and managing how long children and youth wait for surgery. The system itself addressed the full spectrum of conditions in children and youth and used common standards called the Pediatric Canadian Access Targets for Surgery, or PCATS, which enabled the national benchmarking report. So more will be spoken to that shortly. The project was self-funded from the time Health Canada ended funding until it transitioned to the Canadian Pediatric Decision Support Network in collaboration with CIHI and supported by the Pediatric Surgical Chiefs of Canada. So some of the key transition milestones included the new fields available in the abstracts, which were basically 3 data elements. That was PCAT code, decision to treat date, and surgery date, and they were all added under Project 050 on the CIHI data NACRS abstracts. 9 sites continue to participate through this benchmarking, all of which were past CPSWT project participants. And the bonus for this is that there's the ability of any Canadian hospital are able to submit the pediatric surgical wait times data to CIHI via the data NACRS abstract. This is with the exception of Quebec, as they don't report through data NACRS, but they do submit data, or they have the ability to submit their data manually directly to CAPC CPDSN for the inclusion in benchmark reports. And finally, quarterly reporting through CIHI portal for participating CAPC CPDSN members is available. So with that, I'm going to hand the baton over to Dr. Frankie Frolin to speak a little bit about the importance of PCATS.
Thank you, Yuri. Good afternoon, everyone. What I'm going to talk about is some of it's already been said, so it's a reiteration and just a review. Today you will hear a proposal which is much needed. PCATS, or Pediatric Canadian Access Targets for Surgery, is a diagnosis-based priority system of codes. And as you know, each code is a diagnosis that is classified into one of 7 target times for surgery, from within 24 hours to within 12 months. Mary's going to start us off by reviewing how these codes came into being in 2008. And my understanding is that it was always the intention that these codes would be updated on a regular basis. Last week, Mary very nicely showed us how the Stollery Hospital in Edmonton has used these codes. By having surgeons using the same language, i.e. the same codes, they've been successful in using the data to help individual surgeons with optimal queuing and scheduling of patients.
Did we lose them?
Certain demand. Any coding system needs to be monitored and updated regularly. Sorry? Can everybody hear me?
We thought we lost you there for a minute.
That sounds good.
We can hear you now.
Oh, can you hear me okay?
Yes.
Okay, sorry. Any coding system needs to be monitored and updated regularly. It is time to review the PCATS codes, to identify those codes that are not being used, to identify diagnoses that are not currently being captured, and to review if the target time associated with the code is appropriate. Leah will lead us through a proposal, explain how this update will take place, and she will review how members across the country can be involved to ensure the success of this project. Now on to Mary Muir.
Thank you, Dr. Fraulein. So I'm going to be providing a brief background on how this initiated. So in 2005, the Ontario Children's Health Network developed surgical access targets by pediatric surgical representatives from 10 subspecialties. These were probably considered the first iteration of diagnosis-based access targets with the inherent priorities attached. In 2007, when the Canadian Pediatric Surgical Wait Time Project was implemented, the OCHIN access targets were adopted and used for the project, and upon their implementation, surgeons began noticing that some of these diagnoses were either missed or the target times could be made more accurate. It was decided within that year to update these access targets, and in 2008, after approximately 1 year of use of the OCHIN targets, we revised them based on the lessons learned, and that's when they were given a new name, Pediatric Canadian Access Targets for Surgery, PCATS, to reflect this pan-Canadian perspective. The revision itself was conducted by consensus expert panels of over 100 pediatric surgeons across Canada in their respective surgical subspecialties. The current PCATS list includes wait time 1 and wait time 2 access targets. So the wait time 1 refers to the referral wait, and the wait time 2 piece refers to the surgical wait time. Unfortunately, we weren't able to update wait 1 for 2 surgical subspecialties, being cardiovascular and ENT, as it was at the time thought we wouldn't have enough time for ENT, and cardiovascular, they decided the cardiologists would have been in a better situation to update that piece. The Pediatric Surgical Chiefs of Canada govern PCATS with input from national expert panels across the country. The initial panel that revised the PCATS list that we're used to today recommended reconvening to update these lists annually. A regular revision of these codes would ensure continued involvement and buy-in from pediatric surgeons as well as administrative leaders from healthcare providers across Canada. So we're probably wondering why a PCATS update? Well, there is national interest from stakeholders at participating pediatric academic health science centers across Canada to update these targets to support better data. We want to maintain relevance and provide a more complete assessment of wait times for surgical interventions across the country. The recommendation from the previous expert panel was an annual review of the PCATS list, so we're well overdue with that, as the last enhancement was in 2008. I'm going to pass the baton now over to Leah to continue on. Slide 7.
Okay, thank you so much, Mary. So as Mary was saying, really, the PCATS update proposal, the purpose is very straightforward. The goal is to review the current PCATS codes and provide recommendations for the national enhancements to these codes in support of better data for all. And it comes with the understanding and the underlying assumption that doing this together is really the only way, because we want to continue to be able to benchmark apples to apples. So I thought I would share a few of the project assumptions. At any point in time, as I mentioned earlier, feel free to let us know if any of these assumptions don't fit 100% with you, or if you want us to expand. So the first assumption is there is national interest from all stakeholders for this project. All stakeholders within our scope at this point means the Canada's Pediatric Academic Health Science Centres, the Pediatric Surgical Chiefs of Canada, CAFC, Canadian Pediatric Decision Support Network, the benchmarking program, and the Canadian Institute of Health Information, which is the de facto holder of all the most reliable health information that Canadians use and policymakers use to make their decisions. We figured that if a national expert panel working group was an effective methodology for creating the PCATS codes in the first place, it probably is a very good model to use to make the update for these set of codes. And we know that we have access to some of the previous participants that we can reach out to engage them in the hope that they would come on board for round 2. The ability for a PCATS update exists in local systems. That's one assumption that we are in the process of validating, and that's a very important assumption, and we hope to get your feedback later on through some of the other polling questions we have set up today. Number 4 is PCATS update project has no dedicated funding. Well, we all know in healthcare, I've been in healthcare for over 30 years, that sometimes you have to build it and then they come, and sometimes we have to get very creative in the way we approach getting the information that we need. One thing I do know in my role with CAFC CPDSN is that we are really good as a pediatric community in coming together, collaborating, getting creative, and making things happen, usually for a much smaller sticker price. So we have that going for us, and this is something that we need to be aware in terms of dedicated funding, but it's not necessarily the ultimate barrier. Assumption number 5 really is PCATS update project team will need to rely on contributions in kind. That kind of relates a little bit to number 4. And again, that has been a very effective model for many and all actually CAFC projects, for which I'm sure many of you on the line, as I see who's online, are familiar with. Assumption number 6 is the addition of new PCATS codes and their description into portal does not have an associated CHI cost. This is an assumption, but it is a validated assumption, as CAFC CPDSN has been in discussions with our colleagues at CHI, and we understand through the work of the pediatric surgical wait time transition to CPDSN that if we were to provide CHI with new codes and descriptions, as long as the structure of the data doesn't change, there is no cost to input that into their system. However, number 7, any change to the PCATS codes that will require structural changes to the CHI database may have some associated costs, and those costs would have to be determined based on the volume of codes and the depth of structural changes and the impact to that. So again, these are things we need to be aware of, but they're not absolute barriers. Second, my mouse is not working. There we go. Okay. Great. So PCATS update project team, what can that really look like? So we wanted to give folks a sense of how this may work. So in terms of leadership, we're delighted that Alberta Health Services, namely the Stollery Children's Hospital and Alberta Children's Hospital, have been exploring possible contribution as project leads for this proposed project with some admin support as their part of contribution to the national working group. And in a few moments I will ask Mary to share with you why that is so important to Alberta and some of the work that's currently being done there that's very relevant. The conversation about this actually started in April of 2012 when the then surgical chief, Dr. Cole, at the Stollery Children's approached CAFC CPDSN to explore the possibility of a PCATS update project. And so the folks that are online today as your panelists are the folks that have been involved in these discussions with our colleagues at CIHI to kind of explore and see what the opportunities are. And we've done a little bit of groundwork, and that is what we're presenting to you today. In terms of facilitation, it was thought that CAFC CPDSN can be the one to facilitate the work group meeting and coordination of such a project, would be able to support stakeholder communication, light admin support, and a major role in the central liaison with CIHI. CAFC is also willing to explore funding opportunities for potential CIHI-related costs that would be associated to any new codes that may have structural changes as to the points I covered in my previous slides. And we are envisioning that if this was to move forward, the exploration for funding opportunities should take place concurrent to the project work, because that certainly, hunting for money takes time. In terms of facilitation, CIHI will be the conduit to inform vendors about PCATS update and timelines for implementation, and this is a very important and key role because, as you well know, whether it's surgical wait times PCATS or it's ICD-10 codes, whatever that is that you're using from your vendor that codifies and categorizes your information, vendors need lots of lead time to be able to respond to the changing landscape and be able to facilitate that work. So this connect is a really important one, and the CIHI team is on board with this. So for project teams, so that's speaking to you out there listening to us here, really we're looking to recruit previous expert panel participants that may be interested in contributing to a PCATS 2.0. And there's many opportunities for new subject matter experts to participate as well. We need local level surgical wait time site leads that are involved in the day-to-day work of collecting this data, reporting this data, and using this data, and of course our CIHI representative at these project team meetings to keep us on the straight and narrow. I'll stop for a moment here just to see if there are any questions that have come up from our audience. And I don't see any, so I think we're good to go to continue. So as with any project, there are dependencies. The first three dependencies that are mentioned here are ones that have a check mark because we have vetted and are aware of the view of the CAFC CPDSN full steering committee, and we've received project endorsement to go ahead with this important project. It's seen as a high priority. We've also received project endorsement from the Pediatric Surgical Chiefs of Canada, which is the governing body of PCATS. And we've had many conversations with CIHI. CAFC CPDSN has annual retreats with the CIHI team from various departments within CIHI, and certainly this is also of high interest to CIHI. So at this junction, what we're looking to cover off and move forward is the commitment of resources for such a work group or project team. And it's very important that this project team reflect national representation. We need to look at finding funding to cover potential CIHI implementation costs, and to really get a sense from the local level what the state of readiness can be for implementation, so that can translate into resources, timelines, lead time, and we'll talk more about that further on. So in terms of PCATS update recommendations, the surgical wait times work group that has first brought up the discussion about the need for this, as we were looking at pediatric surgical wait times data and starting to pull our first reports, the conversation naturally went there, and we know that several organizations are experiencing the fact that a lot of records go into the other category. In other words, the current PCATS standard is not robust enough to capture some of the diagnoses that are actually the reality. So in the next revision, it should be built on existing PCATS lists and incorporate the feedback received to date from participating hospitals about use of specific codes. And we've seen many examples, and those examples are across our nation, so we know that the challenge exists for everybody. We want to look at subspecialty services. Pediatric surgeons and Cross Canada representation on expert panels should also be considered, and this is a key success factor in the development of PCATS. And we need central coordination for resources and technological changes. So this is assuming that sustaining organizations will continue to utilize the PCATS list for data collection, and that participating hospitals would be required to integrate the revised list into their local systems. And there's, of course, a very important education and communication piece to the users, and then be able to enable it for benchmarking purposes. So at this point, I'm just going to share with you 2 slides. I'm sorry about the small print. I hope it's a little bit easier. You're going to have to get friendly with your monitor. And this is really a high-level overview of how we started and where we are today and where we think we're going, again, at a 30,000-foot level. So you recall that I mentioned how CATS CPDSN was initially contacted by
and there's interest in also sustaining and spreading into all pediatric activity in the province. Having said that, we know there's a need for an update to the codes, and would we like to start with the existing list, or could we have a more comprehensive list to move forward with? And I think that's where this really intensified for us. And obviously we're looking at different options to assist with this process, and we're looking at hopefully the fall to really cement something. Back to you, Leah.
Thank you very much, Mary. And Samantha is working hard to bring the screen up. Hopefully this is easier for people to visualize. So the first couple of squares to the left of your screen are really where it started. It actually started, as I said, in April in 12. And you could see that discussions were happening with a proposed project plan that was presented to CATS CPDSN Steering Committee at our retreat in 2013. Following that endorsement, we presented a couple of days later to PSCC, and we know that we wanted to move ahead together, and we also had some discussions with CIHI prior to that to create the project plan. So the dates that you will see on this plan, again, they are projected dates. This is something that, should this project go forward, we would need to tweak based on some of the information we will learn from those who want to participate. So the second last square from the right, participation will be on a voluntary basis, and we are looking to set up a work group or a project team sometime in the September-October timeline, with meetings that would start monthly teleconferences anticipated to be about an hour and a half long in November of 2014. Those teleconferences would be led by a chair and supported through our surgeons-in-chiefs, and we would be looking for participation from all participating centers. So we'd be looking for content experts from the initial project. We're looking for clinical expertise, program directors, manager, data analysis. So we are looking really for a multidisciplinary and faceted project team. Regular updates and feedback will be going to CPDSN steering committee and to PSCC, and communication plan will be established and will be activated to all participants so that everyone is kept in the loop. And I'll just move on to the next slide. We will keep our colleagues Kai-High in step with every move. I don't know if many of you are aware, but CAPC CPDSN meets biweekly with our Kai-High colleagues. So there's lots of infrastructure already set up in terms of project management to support this project. We have ensured that this project actually is on the Kai-High priority agenda because in our discussions with Kai-High about the milestone dates, so if we wanted to target, let's say, April 2016 as a go live for a PCATS update implementation, you will see on this flow chart here, this is sort of the final date that Kai-High has identified. That's September 30th, 15. So we sort of began with the end in mind and worked backwards. So to be able to meet that date, we know from at this point that come the fall, we will be meeting again for the CPDSN retreat and for PSCC meetings, so we could give an update and about the progress of participation towards the PCATS update. And we anticipate that this will take probably this year and the better part of next year to be able to review the codes, come up with a list of recommendations, come to consensus, feed that information to get all stakeholders on board, and then a final submission to Kai-High for the build on September 30th, 2015. So that's sort of at this end. A very important end, of course, is at your end, and so we need to understand how much time is reasonable and realistic for local readiness. So we estimated a minimum of approximately 6 months. It's not carved in stone, and we're going to ask you to provide feedback on some other options. And we really need your feedback on this, and the plan could be adjusted accordingly. It is really important that we get this piece right because we understand that the vendors usually need a good 4 to 6 months. Whether that's the same 4 to 6 months and concurrent work could be happening at the same time. But you know, no matter what great tool you build, we all know that the success of an implementation is local readiness, buy-in, education, and support. So this is a very key piece. We see the integration of the new PCATS codes and descriptions in Kai-High's DAD and NACRS manuals and user education activities. So again, a 6-month timeline here is a minimum. The Kai-High implementation will follow a regular portal update cycle, and that would be monthly. And so we are looking then at also to provide enhanced PCATS code lists to our Quebec members. I know currently on the call today we have 2 interested members from Quebec. And as Yuri mentioned before, because Quebec reports through MedEcho, not the DAD, and Quebec data actually gets converted into a DAD format, our Quebec colleagues are not able to provide surgical wait times data currently through the DAD, so they do it manually. So we have to make sure in this project that this piece gets it right too, and they need their timeline to be able to integrate their data. All this data then gets pulled out of the portal and integrated with the Quebec data for reporting. So there are several pieces here that we need to be aware about, both at the local level at Kai-High and then at CPDSN in terms of timelines. And the vision is that once we do this, the dissemination of national surgical wait times reports to participants will follow the regular quarterly cycle that we are established as of this year, but that the data would be even better than what it is currently because it's going to be more robust and it would have a broader scope. I'm not sure if everyone online is familiar with ICD-10 coding intimately, but if you think of the ICD-9 and then the ICD-10, that was a lot of work. This is not as much work, but think about what the big value add was in terms of our ability to slice and dice the data and put it in better context. So in terms of next steps, really we need to confirm that Alberta Health Services are able to provide some project leadership and admin resources, and I say that with utmost respect and no pressure, folks. It is great that we have a colleague that has brought this to the level of engagement that we are experiencing recently, and we are looking forward to working together to see how that can work out. And we are looking towards more stakeholder engagement and follow-up to confirm that PCATS update work groups and commitments will have the membership it needs. We are looking at setting up the meeting schedule to start in November 14. We need to refine and update the draft project plan, reach out to collect PCATS code update requests to feed how this work will flow, confirm project timelines with CIHI to make sure that no changes are happening at their end, and really develop and implement, and this is very important, a project communication plan. So where do we go from here? Really, we would hope that as representatives for your organization on the call today, that you would take this slide deck, which will be made available on our website, share it with your colleagues, continue the conversation, email us with any questions, in addition to the feedback that you will provide momentarily, and keep the conversation going and really think about what would work best for your organization, what would the value proposition be, and how you can get involved so we can get this off the ground. So now it's your turn. I've talked way too long, and I'm just checking. I don't see any questions from anybody, so we're going to ask you some questions then. So I'll turn the baton over to Samantha to lead us in our polling questions. Okay, Samantha doesn't want to read them, so I will. So the first question, in your opinion, how often should a standard coding system like PCATS be updated to keep it relevant? So please select one. Okay, so over half of you have voted. We should have some good music playing in the background, I think, for this portion. I have always thought that. Ding, 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 ding.
That's the kind of music I was thinking of, too.
Yeah, I bet we were all thinking the same thing. Okay, we're at 63%. Keep them coming. Okay, great. And the results are in. So 20% of you think an annual update is the way to go. 40% of you are deadlocked between 2 years and 3 years. So maybe we should have a section that says every 2 to 3 years, and that would capture the 80%. So that's very interesting, and it makes total sense to me. The next question, I think Samantha's going to read it.
I'm ready now.
Yes.
Do you believe there is a need to enhance the current PCATS list? If yes, why? If no, why not? So you're able to select an option here, and then if possible, we ask that you sort of elaborate on your answer within the chat box, just so we can kind of get a better idea of what's out there. A few answers coming in here. I'll just give people some time to type in their answer from the bottom. All right, so close that and share it.
Okay, so 75% of you think there is a need to enhance the current PCATS list, and 25% no. And we're not seeing anything in the chat, so I would be very interested in hearing for those folks who have said no as to why you think there is no need to enhance the current codes. This would be very informative. So we'll give it another minute or so for folks to give us their feedback if you so wish. Okay. All right. So we'll move on to the next question. How long do you think your organization will need to prepare at the local level for a PCATS update implementation? We're going to ask you to select one again. Less than 6 months, 6 to 8 months, 9 to 11 months, more than 12 months, or unsure.
And Leah, just to quantify this one, it's after the lists have been comprised, right?
Yes. So in other words, the lists are comprised. CIHI has been talking to the vendor. The vendor is integrating those lists in the new system. But there's always that readiness at the local level in addition to that. Okay. Great that everybody, we're getting lots of responses, lots of voting. Okay, on this particular one, we have 50% of the audience who voted. So that's important to know. And the results are less than 6 months is 25%, 6 to 8, 25, 9 to 11, and unsure. So this is interesting, and I think it speaks to the fact that we all have some different systems, some different challenges, and that we need to consider in the project timeline how it's not a one-size-fits-all. So better to be able to go more broadly, I think, for maximum success and support. Thank you, and we're almost done. I think we have one more question, Sam. 3 more, I lied. Over to you.
Okay, so in your opinion, what is the biggest local barrier to participation in this proposed project? So timing of projects, local resources, resource constraints, concern about cost implementation, other. So again, please use the chat box, type in if you have any other barriers, and then unsure. And we're going to follow up with a question asking about the second largest, so you can just choose one here. Okay, so got most of the answers in now.
Okay.
We'll share that off.
Okay, I don't think this will. I'm curious to know whether this would surprise people online. It'll be not showing up.
There you go.
Okay.
Isn't that interesting?
100% for local resource constraints.
Yeah.
I don't know if any of the panelists want to comment on that. Does that surprise anyone?
It's not. It's Elaine. It's not surprising to me at all. It's very helpful to have this particular poll question because I think this tells us a challenge that we have to address collectively. So I really appreciate everyone's response on this for sure. And this is interesting how there's 100% consensus on that.
Mm-hmm.
Yeah, it's important, very important.
Okay, thank you. And now we're going to ask you for the second biggest local barrier to participation. So I know it might have been hard to choose. So we have the same list, the timing of the project, local resource constraints, concern about cost, other, and unsure. So please, what is the second barrier in your opinion? Okay, I'm going to share the results of that. Okay. I was just on mute and saying to Sam, I bet it'll be timing or cost, and we were trying to figure out which one that would be, and they came in 50%, so we have a tie for second. Okay. And last but not least, you've been such a patient and engaged audience. We'd ask you to rate your interest in participating in a PCATS update project. Select only one, please. Wahoo! It's about time. Moderately, not at all, or unsure. Okay, we're almost done. We're getting great participation.
Trying really hard not to giggle at the first option, Leah.
Oh, you could giggle. We're allowed. Just because we're doing work doesn't mean we can't smile, right? Okay. So it's about time, 20%, moderately 60%, not at all 0. That's music to my ears. That's awesome. And unsure 20%. Okay, that's really helpful. And that concludes our polling questions. And again, I can't extend enough appreciation for everyone's time and for sharing your thoughts with us and your opinions. At this point, we hope that if you have any other questions, you would send them in to us, again, through the chat. If you want to pose a question to any one of our eager panelists, or if any of our panelists would like to make a comment, that would be well appreciated as well. So I'm opening it to the floor.
Leah, it's Elaine, and I'm going to put a question out to our fellow panelists and any of our colleagues participating. I'm just wondering, and maybe I can even direct this question to Dr. Wright just to maybe kick it off. Jim, in terms of the value add, what this new knowledge, and I'm speaking about knowledge and access to these data that we have had really for the last 4+ years, what impact can, and I know there's been tremendous impact, can you speak to that? Because I think that's something that really is important to be a part of a webinar like today, part of our key messages to really bring something, the so what factor is what I'm getting at. So I wonder if I could ask you to speak to that a little bit, and I'm sure others may want to comment.
Sure, it's my pleasure, Elaine. So this is the major project for the Pediatric Surgical Chiefs of Canada, and I recognized a need of children not meeting their timely access to surgery. And so this started as kind of a small project and became ever larger. And it's, I think, the only wait time system that's universal across the entire country. So virtually every situation in which people want to talk about access for surgery, they talk about a common language that can be used whether you go to a hospital in Newfoundland, Ontario, or BC. And I think we're the only group that's been able to achieve what I think is a huge accomplishment, allowing us to ensure that every child who comes to surgery has a consistent access target. So that's one thing. The second thing is this has placed it on the national and provincial agenda, whereas previously I think many people assumed that children don't wait for surgery like adults do. And so there are many provinces where this has been influential in driving public policy, in focusing attention on an area that I think was previously underappreciated. For example, children waiting for dental surgery, I think was a a national crisis which really hadn't been thought of or considered except among those clinicians who are focused on oral health. The third thing is it's allowed us at a provincial and hospital level, Mary Muir. In some cases additional resources, but in other cases it's just reallocating resources in a more rational way. So many hospitals use this to allocate operating room time, an extremely valuable resource, but it's provide a rational basis for allocation of this extremely valuable resource, and in so doing has substantially improved access within their institution. So I see PCATS as an incredible partnership between CAFC, the CPDSN. Barb and Leah have been fantastic. It's also created a national, allowed us to partner with CIHI, which is a fabulous organization which has a national mandate to report and monitor health delivery in this country. So I'm so pleased and proud to be part of it. I can understand why local institutions would see, the PCATS is doing a reasonably good job, and there certainly is the need for some local resources if we were going to do some changes. I don't think the changes to PCATS 3 would be huge, so I don't think it's going to be a huge amount of reprogramming either locally or at CIHI, but I do think we need to respect the clinicians who use this on a daily basis and say there are some improvements that we could do. So I'm very excited in what I see as a natural evolution. Just like ICD-9 went to 10, PCATS needs to go to PCATS 3, and so I'm enthusiastic, I'm optimistic, and I'm hoping this won't be a huge either effort or resource requirement. There'll be some, but I'm hoping it won't be major. Does that answer your question, Elaine?
Oh, it sure does, and I think it just adds more insight to the fantastic presentation today. I really, really appreciate that, Jim. I'm not sure if anyone else wants to sort of add from their lens or their healthcare institution, etc.
Sean here in Edmonton at the Stollery. You've just highlighted the importance on a national level, but oddly enough, even though there's some nationally consensus, there's a lot of local improvements that are made as well. Given the normalized databases for which you are comparing patients to patients, you have improved work between the different departments. So you have the booking office working differently with the OR, and the booking office working differently with the surgeon's offices. And then the surgeon groups themselves as subspecialties are looking at care differently and ensuring that the patients get care that is clinically focused as opposed to individual areas of focus, so that it's not just the booking office needs that are met, it's also the surgeon's office's needs that are met, and vice versa. It just provides overall a lot of synergy, and the more we can beat the odds that actually continue to have some national benchmarking, the better off our patients will be nationally, I think, and locally.
John, it's Elaine again, and I'm not going to dominate the conversation, I promise, but you're reminding me of something that I actually wanted to ask on last week's webinar, Mary, following your presentation, but maybe to Sean and Mary. Have we had any feedback, any formal way of tracking family satisfaction or reaction, any sort of feedback over the last few years? You know, we know that the unsatisfaction or the dissatisfaction from families and having to wait and that sort of thing, has that changed attitude at all? Have we seen, felt any of that? Have we measured any of that?
Well, it's Mary here. I'll weigh in on that one a little bit, Elaine, in the sense that some of our surgeons are using these target times at the clinic level when patients are asking them, how long should I expect to wait? And they'll pull out their PCATS list and say, well, the recommended target time is, so we're hoping to get you in within the target time. And just the appreciation of that alone has really come to the forefront for many of our users. That's the appreciation. I think it probably would be noted more so at the surgeon level. We don't hear about that so much in our offices. We're not interacting with the patient as much as the surgeon is, but we have had those comments.
I think, and here I'll throw this one out, I really think this is perhaps a political thought and response, but that's the kind of information, those are the stories, if you will, that would be really important on our collective parts to reiterate to government, to the politicians, who this would be really important to them, that we are making a difference. It's not something that we should just sort of, nice to have or a warm and fuzzy bit of data. I do think it's really important to try and continue to measure that because ultimately that's why we're doing it.
Yeah, I agree. And we have done some patient focus groups to try to capture some of that information. It was difficult to do, actually.
I'm sure, absolutely. This is tough to measure, no question, Mary, yeah.
Can I add to that, Elaine? It's Jim Wright speaking again. In the province of Ontario, we have a separate procedurally based wait time system, which isn't granular enough, I believe, to allocate the resources in as meaningful a way as the PCATS does. But to go to your point of politicians, at the Hospital for Sick Children, at our peak, about 50% of children were not meeting our PCATS times, and it's now closer to 10%. It runs between 11 and 13. So whereas at a provincial level, meeting our target of 180 days, we've seen very modest improvement across the entire province, because obviously 6 months, you can do a lot of improvement within that. Or pretty much every child gets their surgery within 6 months in the province of Ontario, so you don't see much improvement. So, in fact, there's a great story to be told with PCATS, which is being hidden in a provincial threshold of every child should have the surgery within 6 months.
Yeah.
So that's a case that I've made. The other comment I wanted to make in terms of using PCATS is there's going to be an article published in Pediatrics, which is the prime journal for pediatricians tomorrow, which looks at the Hospital for Sick Children and relates PCATS codes to socioeconomic status. And it shows reassuringly in 35,000 surgical procedures that, at least in the province of Ontario and sick kids, that socioeconomic status doesn't affect your access either for your initial appointment or your access to surgery. So again, this is a great news story that politicians can say, using a granular wait time system, that socioeconomic status in a publicly funded healthcare system doesn't influence. So PCATS has multiple purposes. It can be used for allocation of resources locally. It can be used to benchmark nationally, but it also is a wonderful research tool. So I've got a Canada Press interview later on today, so maybe, hopefully, you can read about PCATS in the news tomorrow.
That's absolutely fantastic, Jim, and I just think that these key points that we're focused in on now, well, first of all, like the publication that you're referencing, the media, interview and article, I think we need to, we talk about capacity and the workload, and this is a real reality. But at the same time, I think we need to be reporting this information as well. We need to make sure that we cite the publication in pediatrics on the CAFC Knowledge Exchange Network, on the CAFC CPDSN site. These are the kinds of things, and at this point we have perhaps evaluation data from CPDSN from Ontario, some from Alberta. That's the kind of thing we need to be including in our benchmarking report. And we need to be, quite frankly, tweeting about when there's, when we reach a milestone in our reporting, because we really have to make sure that in addition to our community, our families, our politicians, our decision makers are hearing about this. Congratulations on the publication, by the way. That's terrific.
Yeah, it's exciting.
Indeed, it's very exciting. Okay.
Back to you, Leah, I guess.
Any other comments from anyone? No? Okay, so in terms of next steps, I would like to let everyone know that we, the group that has been presenting and sharing with you this great need today and the vision forward, will continue to work to confirm leadership and admin support resources. We will be sending participants of today's webinar the link to access the slides for today, as well as point you to last week's presentation on the value of surgical wait times, the Stollery experience. We will follow up with you to keep you abreast over the coming weeks of progress at this end, and we look forward to hearing about progress at your at the site level towards participation. So we hope you keep the conversation going. And a call for participation for the actual project team will likely go out in the early fall time frame once we have leadership and admin supported sorted out. And at any point in time, please feel free to contact me with any questions or comments. And I'd like to thank all the panelists today for joining, taking the time, and working together to share the vision so passionately with everyone. And I wish you all a good day.
Thank you, Leah. You too.
Thanks everyone. Bye-bye.
Bye.